Welcome! Today we are diving into the fascinating world of the adrenal gland. We will explore its physiology, the hormones it secretes, and the pharmacology of corticosteroid drugs used in clinical practice. Let's start with an overview. The adrenal gland has two functionally distinct regions. The outer cortex makes up 90% of the gland and secretes steroid hormones. It is divided into three zones: the glomerulosa, fasciculata, and reticulata. A helpful mnemonic is GFR, corresponding to salt, sugar, and sex. The inner medulla makes up the remaining 10% and secretes catecholamines like adrenaline. Before we get into specific hormones, let's contrast peptide and steroid hormones. Peptide hormones are chains of amino acids that bind to cell surface receptors. Steroid hormones, on the other hand, are all derived from cholesterol. They are highly lipophilic, meaning they aren't stored in vesicles but synthesized on demand. They cross cell membranes to bind intracellular receptors, directly altering gene transcription. Moving to the outermost zone, the zona glomerulosa secretes aldosterone. Its primary triggers are angiotensin II and high potassium levels. Aldosterone binds to mineralocorticoid receptors in the kidney's collecting ducts. It upregulates sodium channels called ENaC and potassium channels called ROMK. The net result? Your body retains sodium and water while dumping potassium and hydrogen, which can lead to hypokalemic metabolic alkalosis. Aldosterone doesn't just act on the kidneys. It also conserves sodium in the colon, salivary glands, and sweat glands, which is vital for heat acclimatization. In the heart, excess aldosterone causes cardiac fibrosis. Interestingly, in conditions of chronic excess, like Conn's syndrome, patients develop hypertension, but not edema. This is due to aldosterone escape, where the expanded blood volume triggers ANP release, forcing the kidneys to excrete sodium and prevent swelling. Next is the zona fasciculata, which produces cortisol. Cortisol is our primary stress hormone, producing about 10 to 20 milligrams daily. Its release is driven by ACTH from the pituitary gland, which follows a strict circadian rhythm, peaking in the early morning to wake us up and dropping at midnight. Stress, pain, and low blood sugar can also trigger its release, while high cortisol levels create a negative feedback loop to shut off production. Cortisol has massive metabolic and immune effects. It raises blood glucose by stimulating gluconeogenesis and causing insulin resistance. It breaks down muscle protein for energy and redistributes fat centrally, which is why chronic excess leads to a moon face or buffalo hump. Immunologically, it is profoundly anti-inflammatory. It blocks the arachidonic acid cascade by upregulating lipocortin, effectively shutting down prostaglandin and cytokine production. Beyond metabolism, cortisol is vital for cardiovascular stability. It has a permissive effect on catecholamines. Without cortisol, your blood vessels simply won't respond to adrenaline, leading to refractory hypotension. It also stimulates alertness in the brain, though excess can cause psychosis. In fetuses, cortisol is absolutely essential for lung maturation and surfactant production, which is why we give synthetic steroids for threatened preterm labor. The innermost cortical layer, the zona reticularis, produces weak androgens like DHEA. While this is a minor source of hormones for males, it is the primary source of androgens for females, which are peripherally converted to estrogens, especially important after menopause. The maturation of this zone around age 6 to 8 is called adrenarche, triggering early signs of puberty, like body odor. Deep inside the gland is the adrenal medulla, essentially a modified sympathetic ganglion. It secretes mostly adrenaline and some noradrenaline. The conversion of noradrenaline to adrenaline requires an enzyme called PNMT. Here is a crucial physiological pearl. PNMT only works in the presence of very high cortisol levels. Because the medulla is bathed in cortisol-rich blood flowing down from the cortex, it can efficiently produce adrenaline for our fight or flight response. Now, let's look at corticosteroid pharmacology. Both glucocorticoids and mineralocorticoids work by diffusing into cells and altering gene transcription. But here is a fascinating problem. Mineralocorticoid receptors bind cortisol and aldosterone equally well, and we have 1,000 times more cortisol. How does aldosterone ever get a turn? The kidney has an enzyme called 11-beta-HSD2 that deactivates cortisol into cortisone, protecting the receptor and allowing aldosterone to do its job. Pharmacokinetics matter immensely here. Endogenous cortisol is tightly bound to corticosteroid binding globulin, or CBG. However, synthetic steroids like dexamethasone have very low affinity for CBG and bind loosely to albumin instead, resulting in a much higher fraction of free, active drug in the blood. Also, remember that prednisone is a prodrug. It must be activated by the liver into prednisolone. If a patient has severe liver failure, always prescribe prednisolone directly. This table is critical for clinical practice. We use hydrocortisone as our baseline, with a potency of 1 for both glucocorticoid and mineralocorticoid effects. Notice how synthetic drugs alter this balance. Prednisolone is 4 times stronger for inflammation. Dexamethasone is up to 30 times stronger, with 0 mineralocorticoid activity, meaning no salt retention. Conversely, fludrocortisone has massive mineralocorticoid potency, used specifically to replace aldosterone. While powerful, corticosteroids have severe adverse effects. They can cause steroid-induced diabetes, osteoporosis, severe infections, and fluid retention. But the most dangerous complication of chronic use is HPA axis suppression. If you give exogenous steroids for weeks, the adrenal glands stop producing their own cortisol and atrophy. If you abruptly stop the medication, the patient can crash into a life-threatening adrenal crisis. Let's look at specific drugs. Hydrocortisone is bioidentical to human cortisol. Because it has a 1-to-1 ratio of glucocorticoid to mineralocorticoid activity, it is the perfect physiological replacement for Addison's disease. We also use it in high doses for septic shock to restore vascular tone. Just be aware that at those high doses, its mineralocorticoid activity will cause significant sodium and water retention. Prednisone and its active form, prednisolone, are the workhorses of outpatient inflammatory disease management. With 4 times the anti-inflammatory power of hydrocortisone and slightly less salt retention, they are ideal for asthma flares, rheumatoid arthritis, and autoimmune diseases. We typically dose them once daily in the morning to mimic the body's natural cortisol peak, which helps minimize suppression of the adrenal axis. When you need massive anti-inflammatory effects without any fluid retention, you turn to methylprednisolone or dexamethasone. Methylprednisolone is great for high-dose IV pulse therapy and transplant rejection. Dexamethasone is incredibly potent and uniquely crosses the blood-brain barrier, making it the drug of choice for cerebral edema and meningitis. It is also the steroid proven to reduce mortality in severe COVID-19. Finally, fludrocortisone is our synthetic mineralocorticoid. It is incredibly potent for retaining sodium and is taken orally. It is absolutely essential for patients with primary adrenal insufficiency or Addison's disease because their glands cannot make aldosterone. However, patients with secondary adrenal insufficiency, meaning pituitary failure, do not need it because their kidney's ROS system is still perfectly capable of stimulating aldosterone production. Let's wrap up with some high-yield pearls. Remember the GFR zones for salt, sugar, and sex. Don't forget that 11-beta-HSD2 is the enzyme protecting your kidneys from cortisol overload. Always remember prednisone is a prodrug, and that synthetic steroids bind albumin, not CBG. Finally, respect the HPA axis. Chronic steroid use causes adrenal suppression, so always taper these powerful medications carefully. Thank you for watching.